Necrosis. The term necrosis was first used by morphologists to refer to a series of changes that accompany cell death, largely resulting from the degradative action of enzymes on necessarily injured cells. Necrotic cells are unable to maintain membrane integrity and their contents often leak out. Morphology of necrosis including nuclear changes and cytoplasmic changes. Nuclear changes assume one of three patterns, or due to breakdown of DNA and chromatin. The basal filling of chromatin may feed, called karyolysis, presumably second to DNA activity. A second pattern is pynosis, characterized by nuclear shrinkage and increased basophilium. The DNA condenses into a solid shrinking mass. In the third pattern, keraxis, the pynotic nucleus undergoes fragmentation in 1 or 2 days. The nucleus in a dead cell completely disappears. Cytoplasmic change including increased eosinophilium and homeogenesis. This is attributable in part to increased binding of eosin to denatured cytoplasmic protein and in part to loss of the basophilium that is normally imparted by the RNA in the cytoplasm. When enzymes have digested the cytoplasmic organelles, the cytoplasm membranes vacuolated and appears moth-eaten. Dead cell may be replaced by large, halted phospholipid masses called myelin fibrils that was derived from damaged cellular membranes. These phospholipid precipitates are then either phagocytosed by other cells or further degraded into fatty acids. Calcification of such fatty acid residues result in generation of calcium salts. By electron microscope, necrotic cells are characterized by discontinuous in plasma and organelles membranes, marked dilation of mitochondria with the appearance of large amorphous densities, disruption of lysosomes, intracytoplasmic myelin fibrils, and profound nuclear changes culminating in nuclear dissolution. Patterns of tissue necrosis. There are several morphological distinct patterns of tissue necrosis, which may provide clues about underlying causes. Coagulative necrosis is a form of tissue necrosis in which the component cells are dead, but the basic tissue architecture is preserved for at least several days. The affected tissue takes on a firm texture. Presumably, the injured denature not only structure protein but also enzyme, and so blocks the proteinalysis of the dead cells. As a result, eosinophilic, a nucleolate cell may persist for days or weeks. Ultimately, the necrotic cells are removed phagocytosis of the cellular debris by infiltrating leukocyte and by digestion of the dead cell by the action of lysosomal enzyme of the leukocytes. Coagulative necrosis is characteristic of infects in all solid organs except the brain. Liquefative necrosis is seen in a focal bacterial or occasionally fungal infections. Because microbes stimulate the accumulation of inflammatory cells and the enzymes of leukocyte digest the tissue. For obscurism, hypoxic death of cells within the central nervous system often evoke the liquefative necrosis. Liquefaction completely digests the dead cell, resulting in the transformation of the tissue into a liquid vascular mass. If the process was initiated by acute inflammation, the material is frequently green, yellow, and is called pus. Gangrenous necrosis is not a distinctive pattern of cell death. There are forms of gangrene. Dry gangrene is usually applying to a limb that has lost its blood supply and has undergone coagulative necrosis involving multiple tissue layers. The necrotic area appears black, dry, and shin-waved and is sharply demarcated from adjacent variable cell. When bacterial infection is superimposed, coagulative necrosis is modified by the necrophatic action of the bacteria and the attacked leukocyte. The necrotic area becomes swollen and reddish black, with extensive liquefaction of the dead tissue. Gas gangrene is a wound infection caused by Clostridium perfringens and other clostridial species. The gross appearance is similar to the wet gangrene, with the additional presence of gas in the tissue. Caseous necrosis is encountered most often in the foci of tuberculous infection. The term caseous is derived from the friable yellow-white appearance of the area of necrosis. On microscopic examination, the nephrotic focus appears as a connection of fragmented or lysed cells with an amorphous granular appearance. Unlike coagulative necrosis, the tissue architecture is completely obliterated and the cell outlines can't be discerned. Caseous necrosis is often enclosed within a distinctive inflammatory border. This appearance is characteristic of a focus of inflammation known as a granuloma. Fat necrosis is a term that is well fixed in a medical parlance, referred to a focal area of fat destruction, typical result from the release of activated pancreatic lipases into the substance of the pancreas and the peritoneal cavity. This occurs in the abdominal emergency known as acute pancreatitis. In this disorder, pancreatic enzymes that have leaked out of the actinal cells and the ducts liquefy the membranes of the fat cells in the peritoneum. The lipids slipped triglyceride esters contains within fat cells. The release of fatty acids combine with calcium to produce grossly visible chalky white areas, which enable the surgeon and the pathologist to identify the lesion. On histological examination, the foci of necrosis contain shadowy outline of necrotic fat cell with basophilian calcium deposit surrounded by an inflammatory reaction. Fibrinoid necrosis is a special form of necrosis, usually seen in immune reaction involving blood vessels. This pattern of necrosis is prominent when complex of antigen and antibody are deposited in the walls of the arteries. Deposits of this immune complex together with fibrin that has leaked out of the vessel, resulting in bright pink and amorphous appearance in HE staining, called fibroid by pathologists. The immunology-mediated disease like polyarteritis nodosa, in which this type of necrosis is seen. That's all for this section. Thank you.